Our first panel today is made up of physicians and rare disease advocates. Tammy Boyd is the Chief Policy Officer and Senior Counsel for the Black Women's Health Imperative, which recently launched the Rare Disease Diversity Coalition to address the challenges faced by rare disease patients of color. Annie Kennedy is the Chief Policy, Advocacy, and Patient Engagement at EveryLife Foundation for Rare Diseases, a nonprofit dedicated to empowering the rare disease patient community. And finally, Dr. Debra Regier is the Medical Director of the Rare Disease Institute at Children's National Hospital. She cares for patients with genetic and metabolic syndromes, manages day-to-day workings of the Institute, and conducts needed research on rare diseases. Welcome to you all.
Thank you.
So just to start off with, and Annie, I'll pose this question to you and you can kick us off. When I hear the term rare disease, as someone who doesn't work in a medical field, doesn't cover medicine or healthcare, my mind goes a million places. Just try to paint a picture for us as to what we're talking about when we say rare diseases and, who's actually impacted by rare diseases. What kinds of patients are more likely to contract them?
Sure. So we actually conducted a study that we published earlier this year that actually started to develop some real data around who's living with rare diseases in the U.S. And we found that of the data that we looked at in 2019, there were more than 30 million Americans living with rare diseases. One of the hard things about this data is that our rare disease community is actually pretty invisible here in the U.S. because the way that we track that data is through a coding system. And then of the estimated 7,000 to 10,000 rare diseases in the U.S., we actually only have codes for 500 of them. So we know that that 30 million number is a gross underestimate of the number of people living with rare diseases. So we probably all have people in our families and in our communities living with rare diseases. We just can't really count them right now based on our data systems. So that interview that preceded us with Representative Eshoo was a perfect tee-up for us to talk about the opportunities to do better by our rare disease community.
Right, and Dr. Regier, what are some of the difficulties that you faced treating patients with rare diseases?
Great question. I think that some of those were actually already brought up in the earlier interview as well. Sometimes it's getting the diagnosis. We don't even know you have a rare disease unless we've made that diagnosis. And since rare things are rare, it's not always the first place that people go when they meet a new patient. So making sure that our healthcare facilities, our physicians, our providers at all levels are prepared to identify and diagnose a rare disease is really important. And then access to care following that diagnosis. So it's the whole pipeline of providing care for families and patients with rare disease. And sometimes we think that it's all pediatrics. I happen to be at a pediatric hospital, but we know rare disease affects people of all ages, children's, adults. I always laugh that I take care of patients from prenatal all the way to the grave whenever that grave is for them, because rare disease affects the entire lifespan.
Tammy, it's interesting. Earlier this week, Vice President Harris held a bit of a summit at the White House talking about Black women facing challenges when it comes to maternal health. And this isn't only an issue when it comes to maternal health. It seems like minorities and people of color really face different standards, unfortunately, when it comes to getting the health care they need, when it comes to treating a disease and getting, like I said, health care. What are some of the challenges that are faced by minorities with rare diseases?
Yes, it's a great question. Generally we can say that rare disease patients have a unique set of care needs and access obstacles from onset of symptoms through diagnosis and access to quality care. But then people of color face their own set of impediments to achieving good health outcomes, from protracted diagnosis delays to reduce access to specialists and treatments that meet the standard of care. And so really it's this layering of access burdens and health disparities that leads to a higher burden of disease and greater mortality in people of color similar with rare diseases. So yes, I mean, in terms of the maternal for Black women, which we advocate for a Black women's health imperative, I mean, the disparities really run across the spectrum, but I mean, it's really no different in rare disease. And in fact, in addition to those unique set of needs and access obstacles, you also have some of the other layering of the access burden and health disparities that lead to a burden of disease.
And can I maybe add to that?
Of course.
We found in our survey that the average diagnostic odyssey in rare disease was over 6 years and included 17 specialists and providers. What's really important, though, while that's staggering if you think about that, that's only representing people who had a confirmed diagnosis, so who got to the end of that diagnostic odyssey, who was able to have a code that, again, we could track, and that's an individual then that was able to navigate a very complex healthcare system that held health insurance coverage that enabled them to get to 17 specialists and providers, and then oftentimes that requires travel out of state and paying for childcare when you were doing that. So I think that really underscores everything Tammy is talking about here, that again, we're creating additional health disparities within our rare disease community because of the complexity of navigating diagnoses and care and needing to really see experts and specialists within a very complex specialized community.
Annie, you make a really interesting point talking about the cost of childcare, the cost of healthcare, having to travel to get healthcare. Tammy, would you say this is an economic issue as well? And, also I'll tack on another question to that. I mean, it's 2021. You have people like the Vice President of the United States looking to really draw attention to these disparities that minorities face in healthcare. What are behind these disparities? Why are we still facing them now when, at least at the surface level, it seems like a lot of major figures, a lot of organizations are trying so hard to make this progress?
Yeah, absolutely. And this is one of the reasons why we launched the Rare Disease Diversity Coalition, which, again, as you mentioned, really brings together a multi-stakeholder groups. It's industry, it's patient advocacy groups, equity groups, rare disease patient advocacy groups as well, and really having everyone at the table to come up with solutions that address the challenges. And I think it really takes just really having everyone at the table collectively. For example, we at Black Women's Health Imperative have been working a lot on ICER and making sure that we include the quality of life and how ICER values life, for example, for Black women. We worked with them on the MG, myasthenia gravis, ICER review, and then also the lupus nephritis review as well. But I think it takes going to deeper and looking at some of those layered areas where we may not be factoring in, for example, in clinical trials. I mean, that is really the guidance for a lot of the data that we have. So we have to make sure we have minorities included in those clinical trials. So I think it's several different issues, but the great part is that I think COVID has really, us in health disparities, we already knew that these disparities were there, but now there sort of seems to be like a renewed momentum to really address and really get to the root causes of why these disparities continue to exist.
And that's such a great point you bring up about COVID, Tammy. I mean, talking to other healthcare professionals at previous events we've done with the Hill virtually, it seems like the pandemic has had such a big impact on the industry, obviously. Dr. Regier, I want to go to you on this one. I mean, how has COVID impacted the treatment of rare diseases as well as the research into rare diseases?
Yeah, when you think about the treatment of rare disease, we have this saying in the rare disease population of our families know how to quarantine. Our families knew how to hunker down and stay safe like none others. They have community. They have an amazing bandwidth to figure out how to navigate complex situations, as we've heard. And they did a great job. It's been amazing to me how the rare disease community, the family communities have, they've stuck up for each other. They're in this thing together and they're finding new ways to live life. The other thing that we've seen is with the launch of so much more telehealth I think that's really helped these communities, especially individuals that might be in rural communities or communities without direct access to a rare disease specialist, by having some of those state lines able to do more telemedicine. It's allowed us to get into homes that we haven't always been able to get into traditionally without telemedicine. So that's been a really big boon to how do we do treatment? How do we keep people at home safely and keep them on treatment even if they can't get into a healthcare facility? And I'll be blunt. Here at our center, we're still at 40 to 50% telehealth because it's the right thing to do for rare disease families. Having them stay home, having them not have to come into a hospital has been really effective at improving quality of life for families. Why are you in our hospital if you don't have to be? And then when we think about research, I think a lot of what we're thinking about now is how do we bring that research table to the population instead of expecting them to come to our table? How do we reach out to them using what we've learned through telehealth? How do we reach out to people in their homes? Research studies that you used to have to come to the center to get that blood draw, to get that exam. A lot of the rules have changed, and we can do those on telehealth, which is amazing. Think about the people I can enroll in a study now if I can do a telehealth research visit instead of having you have to travel 8, 10, 12 hours. It allows people without access to some of those resources for travel to participate in studies. So I don't want to downplay the impact of COVID on our population, but I think taking what we've learned and saying, how can we do better in the future is going to really move rare disease research forward.
Annie, I can't imagine what it's like to have a rare disease or, have a rare disease, let alone during a major global pandemic, and have that extra stress put on me or, whoever has the rare disease. Talk to me about what's it like, what a day in the life is like for a patient with a rare disease, before the pandemic and also during the pandemic.
Yeah, and I totally agree with what everyone here has said. I think it's really important to remember a lot of those wonderful innovations that were just discussed were things that were actually enabled through 21st century cures, and the urgency of the pandemic really helped us to implement them. And there were things that the rare disease community have long been saying we needed and we could have, but the pandemic really lit the fire under us to do it. I do think it's important, though, to remember, and as Tammy was just saying, 60% of the costs of living with a rare disease are actually incurred out of pocket by individuals living with the rare disease. They are not the direct costs that we see in the healthcare system. They're the out-of-pocket costs. They're the non-medical indirect costs. During COVID, those costs were exacerbated because caregivers couldn't come into your home. So the caregiver reimbursement wasn't happening outside of your home. It was now in your home. You were still working, your children weren't in school, and your personal care assistant couldn't come anymore. So that exacerbated that. The other thing is the urgency in rare disease is that the life expectancy for people living with rare diseases is often significantly curtailed. It's estimated about 50% of people with rare diseases won't live to see their 5th birthday. So one of the things that happened during the pandemic was that clinical trials were halted. There were a number of reasons for that. We couldn't screen for the trials. We couldn't enroll for the trials. People couldn't get to trial sites. The exact people at the FDA that were doing the amazing work of reviewing our vaccines and the therapies for COVID were the same people that review our rare disease products. So we had a workforce issue. But when we halt and slow trials in rare disease, we lose a generation of patients in rare disease if we halt trials for 2 years. The other workforce issue we had was that the public health programs that were also being pinched by COVID are our same public health programs that do newborn screening for us. So that hurt our diagnostic programs. And so we, again, have workforce capacity issues that immediately impacted our rare disease community. So we have a lot of solutions before Congress right now to improve workforce capacity. We have to increase funding in rare disease, into research, into diagnostics. We have to make sure those public health programs are reinforced. And if we don't do that, the public health urgency of rare disease will only be exacerbated. The implementation that came out of COVID will not be lasting. And we also have to make up for some of these losses that we had over the last couple of years. The other thing is that we just heard Representative Eshoo talk about the orphan drug tax credit and how incredibly important that has been in innovation. But the orphan drug tax credit is threatened right now. And that innovation isn't just important to companies, but at the end of the day, it's important to companies because it saves the lives of rare disease patients. And just to talk about that for a second, the proposal that's right now in the Build Back Better Act would discourage companies from not the first therapy, but for the second therapy. And what that means is that there are countless examples of rare conditions that benefited when the first investment was approved and they moved on to the second rare disease therapy that may never have been developed if there wasn't an incentive to develop it. And we cannot afford for the rarer of the rare therapies to not have therapeutic development and companies not to have the incentives that are working. So there are so many wonderful proposals that will move us forward, but there are some that could really hurt us if we move those forward. We need to work together to make sure that the promise of innovation is fulfilled for those this generation of patients living with rare diseases.
And on that note about the orphan drug program, I want to pose a question to all of you, and I'll start with you, Tammy. How does one balance the issue of cost as well as innovation when it comes to the development of these orphan drugs?
Yeah, absolutely. And I just wanted to also comment on a point that I think Annie said when you talk about the out-of-pocket costs. I mean, it's even harder on African Americans. So that's even an example in our telehealth. Even as we saw in COVID with telehealth, there's the digital divide. Do minority communities even have access to that? So even as you put those things in place, looking at the systems that also providing access to such things such as telehealth to even be able to do that. And then such as the question around what do we do in terms of the orphan drug tax credit? I mean, we, for example, at RDC, we sent a letter, definitely advocating and pulling those stakeholders together to really just raise the issue around the orphan drug tax credit. But then also, again, there's looking at ICER and how do we engage with them and look at some of their guiding principles. I mean, they see their role as more promoting fairness and taking a payer perspective on things. And so, we have been in there really talking about including minorities, particularly rare diseases, in any of their economical or any of their statistical analysis.
Dr. Regier, we've talked about minorities and how they're impacted by rare diseases and the disparities in the treatment they receive, but I wanted to talk to you about the issue of children with rare diseases and really how widespread this issue is among pediatric patients.
Yeah, and I love that we've already mentioned that if we look at all rare diseases, 50% of children or 50% of individuals with rare disease have a life expectancy of less than 5. That gets into this idea that this has traditionally been thought of as a pediatric issue. So pediatricians are really well versed in rare disease, but we have to remember that the other 50% of the population often makes it into adulthood. So we're trying to expand that education out of just pediatrics. But when we think about my favorite patient population with is peds, that's why I'm here at the Children's Hospital. When we think about how do we ensure that they have access to care, it's one of the reasons that the National Organization for Rare Disorders went ahead and did a Centers of Excellence program to ensure that individuals could identify a place that understood rare disease, hopefully close to their community. This year, they announced 31 locations across the country that are centers of excellence. And by doing that, we're trying to create a network so that we can build best practices. As you can imagine, working with the Black Women's Health Imperative, which has been an amazing organization and have made so much progress, thinking about how do we best ensure that every child with a rare disease is first identified and second has access to care and treatment, regardless of what part of the country they're from, regardless of their background, whether ethnic or socioeconomic. No matter what, we need to make sure we find those children, we find them well, and we give them the best quality of life we can possibly do it. And at the same time, continue to encourage the research we need so that these aren't life-limiting disorders. Instead, they're life-changing disorders. That's always our goal in rare disease. Let's have life-changing, not life-limiting, so we can improve quality of life and outcomes.
So turning our attention back towards Capitol Hill, we heard Congresswoman Issue talk about this, rare diseases and, the work she's putting into this issue. But how many people outside of the Congresswoman on Capitol Hill are actually aware of this issue? I mean, to be honest, it's not something you hear every day in the news media or even in healthcare coverage. And maybe some of that's because of the fact that we're in the middle of a global pandemic and that sort of overshadowed the coverage. But Annie, I'll pose this to you. I mean, is there enough awareness among major stakeholders in Washington on this issue?
So wonderful. I would say there's never enough awareness, but I would say we're really grateful to have our Rare Disease Legislative Advocates Program works closely with the Congressional Rare Disease Caucus. So we have a wonderful group of leaders within Congress who are champions for our rare disease community, work very hard on behalf of our rare disease community. We have a lot of issues that are of great importance to our rare disease community right now, but a lot of really amazing, wonderful opportunities. I think in the context of today, the topic of value assessments in the rare disease community, I think it's really important that as we look at the really critical vehicles before us, HERES 2.0, ARPA-H, PDUFA 7, there are some really important priorities for our rare disease community that have to be front and center and central. And we're grateful to the Congressional Rare Disease Caucus for ensuring that that's the case. But as we look at this momentum and movement of patient-focused drug development that's really taken hold over the last 10 years, and value assessments, we have to ensure that patient-focused drug development is not just informing clinical trials and care and regulatory decisions, but it's also informing our decisions within the access ecosystem. And again, we're looking at the cost of overall care, not just the cost of prescription drugs, because we only have treatments for less than 500 of the 7,000 to 10,000 rare diseases. And we have a lot of data to show that it is not prescription drug costs that are driving the costs in rare disease. And we have to ensure that as we assess what's happening in rare disease, we are looking at how we reduce the overall cost of living with the rare disease overall. And we continue to inform the incentives to improve those health outcomes, as Dr. Regier was just saying, for our rare disease community. That is our number one priority, and we're grateful to Congress for really being champions of that with our greater community.
Right, so we only have just a few minutes left, and I'm going to ask everyone to take out their crystal balls and we'll do a little lightning round. What's the future of research in this field, and what can we expect in the field of rare diseases going forward as we hopefully, knock on wood, get on the other side of this pandemic? Tammy, I'll start with you.
Yeah, I think there seems to be a renewed focus on addressing equity and disparities, that we're going to look at it from a more holistic approach and bringing in the social determinants of healthcare, which again, what you asked earlier, like what are the different layers and why? And so addressing, access to transportation, access to telehealth, access to healthy food, safe environments. So I think looking at it from a holistic standpoint, it's probably what our future is looking like.
Right, and Dr. Regier, we'll go to you next.
Yeah, my crystal ball is we should have a lot of hope and joy in the future. Looking at the past where we've been, we're not there yet, but we have seen improvements in quality of life, and that's where we need to be. That's what we're going to keep doing. We're not going to let this momentum leave us behind. We're going to keep moving forward, improving every day, every life that we can in rare disease.
And Annie, wrap us up.
So the science is here for us. So as long as we invest at the level that reflects the public health crisis of rare disease, our patient communities will have more options, more hope, and more investment in rare disease research that they deserve and warrant.
Ladies, thank you so much for joining us. This has been such an insightful conversation. I know I've learned a lot. I hope our audience has as well. Thank you so much for your time. Tammy Boyd, Chief Policy Officer and Senior Counsel for the Black Women's Health Imperative. Annie Kennedy, Chief Policy, Advocacy and Patient Engagement Officer at EveryLife Foundation for Rare Diseases. And Dr. Debra Regier, the Medical Director of the Rare Disease Institute at Children's National Hospital. Thank you all so much for joining me.
Thank you.
Thank you.